शरीराय गुणमण्डिताय गुणेशानाय
all
धीमहि
the doctors to join.
गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय
Yeah, I'll
श्रीगणेशाय
invite all the doctors to
धीमहि
join for the lamp lighting.
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि आधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Thank you for joining us in lamplighting. It is with immense pride and deep respect that I introduce one of the most distinguished figures in Indian dermatology, a pioneer, a mentor, and a global thought leader, our today's master moderator, Dr. Murlidhar Rajagopalan, a graduate of JIP-MER and a postgraduate from PGI-MER Chandigarh, further honed his expertise with a diploma in clinical immunology. In 1992, he laid the foundation of the dermatology department at Apollo Hospitals Group, and under his visionary leadership, it has grown into a center of excellence. Today, he continues to head the department, inspiring generations of clinicians with his commitment to patient care, academic rigor, and innovation. Dr. Murlidhar is internationally recognized for his
Hello, and a very good afternoon to all the physical and I'm told more than 300 online attendees. And as the program goes on, we will have more attendees. I would like to thank Dheeraj and Pallavi from Glenmark for organizing this meeting. It's important to have Psoriasis Day lectures and discussions on Psoriasis Day rather than 1 week or 2 weeks after that. I do agree that there are exams going on, but I think those who are focused will attend Psoriasis Day lectures and discussions. very grateful to my co-moderators, Dr. Sanjeev Kandari and Dr. Parasramani. Sanjeev is in Delhi and Dr. Parasramani is in Bombay. They will be conducting the sessions in their respective centers, after which Dr. Jennifer will join us. And Jennifer is a good friend of mine. And after Dr. Jennifer joins us, we will listen to her about the theme for today's discussion, and the theme for Psoriasis Day is psoriasis, the domino effect, because we'll discuss why we use the term. So she will talk a lot about comorbidities in psoriasis, and after that we'll have a panel discussion. In the initial 20 to 25 minutes, each center has its own moderator having a small discussion. So I'll be talking about management of psoriasis in a resource poor setting. As you all understand, India is a resource poor setting. How much ever we may talk about being the fourth and there will be a good panel discussion after that. Joints are going to be debilitating, and if you look at psoriasis, most times it produces a disability in the small joints. So it's a very debilitating problem, and joints are affected. The impact is worldwide. In India, we have in some clinics, OPDs itself, just the number of patients who reach an outpatient department. It's about 2.8%. So it's a challenge in a resource poor setting. The other important issue when we talk about a domino effect is that it has effects on areas other than the skin and joints. It has a significant psychosocial impact, leads to depression, anxiety, social isolation, and multiple systems are affected by psoriasis. So the estimated incidence is about 60 patients per 100,000 patients per year. So fairly big incidence of psoriasis. The prevalence, as I told you, ranges from 0.4 to 2.8% depending on where it has been chosen. But most people seem to agree that 2.8% would probably be an understatement of what is actually happening in India. And if you look at the discussions that are going to be there from today morning, started off by Glenmark, and if you look at the IADVL discussion that's going to be there this evening, you realize that 2.8% of India who have comorbidities you are looking at a very serious disease, and in spite of that, we don't have insurance for psoriasis. The chronic plaque psoriasis is the most common morphologic presentation, and almost 90% of patients have this. And it has a higher prevalence in the polar regions of the world. Reasons are very obvious. Phototherapy is one of the best treatments for psoriasis in India. The polar regions don't have that, and the incidence is much more over there. We have specific challenges in countries like India in resource poor settings. Somebody was talking to me before this discussion started that speakers who specialize in a specific topic tend to repeat the same slides and talk only on that same lecture, that same area all the time. I spoke on challenges in resource poor settings in the EADV about 6 years ago. At that time, I did not have this particular slide. So there are differences. And we must understand that in India there is a limited healthcare infrastructure, because after that we did try to talk to the IRDA, we tried to talk to the health ministry, and we found that it didn't make any difference at all. Nobody was interested in looking at psoriasis as a serious non-communicable disease which can lead to multiple organ involvement and a strain on the economy of the country. There's a lack of access to treatment. We don't even have, if you look at India, a large percentage of the population lives in rural areas, and they don't have access. They're not able to get proper health care. The government is trying to get specialists into rural areas, and that we know is not actually happening. There's a social stigma and discrimination, and that's more so in India. There is embarrassment, there's a reduced quality of life, often heightened by a lack of public awareness. There was a paper which I came out with, I think 4 years ago, on treatment inertia in psoriasis. I had wanted to include that, but it would be too prolonged. We find that in India, there is a treatment inertia in seeking treatment for psoriasis, and that's probably one of the highest in the world. Mainly, there's a patriarchal society in India. Women who suffer from psoriasis are rarely taken to a doctor, and the women do not even at home, they don't reveal that they have psoriasis. This is what happens when there is a social stigma. And because of the economic burden and the complete preoccupation with other problems in life, psoriasis is neglected until most times it is a bit too late. The prevalence of comorbidities is also a challenge. Psoriatic arthritis, cardiovascular disease, metabolic syndrome, they can all go unmanaged due to limited resources. Dr. Jennifer will talk more about this. Now, when you classify, when you have a patient of psoriasis walking into your room, there are very high quality and very precise ways of assessing the severity of psoriasis or how badly is the patient affected by psoriasis. So, in all honesty, let me tell you that 99% of Indian dermatologists do not follow this. Most times the dermatologist is going to look at only the body surface area. This thing is not working, so I will not waste your time. They're going to look at body surface area involvement. That's the only thing they look at. So they just look at how bad it appears to be. It's a very rough way of estimation. Whereas actually, if you look at body surface area, mild disease is less than 3% body surface area. Moderate disease is 3 to 10% of the BSA, and severe disease is more than 10% of BSA. This classification is actually very important, even if it is a rough estimate of BSA, because a cheap economical drug, or rather I would say inexpensive economical drug like apremilast, is not given to many patients in India because they don't estimate that in mild and moderate disease this is a good option. Patients are overtreated with strong topical steroids. We have PASI, which is required, that is a psoriasis area and severity index. It's an absolute requirement if you want to do a study on psoriasis, if you want to publish any paper on psoriasis. It's available online, but many of us don't use it. The other important thing is just hand over the questionnaire to your patients. Look at the DLQI, Dermatology Life Quality Index, and that can help you to determine on follow-up how well is your patient responding to therapy. Is the DLQI improving? Is his quality of life improving? But for all that, we need to be bothered about the quality of life of the patient who pays us. There are guidelines which support the assessment. We have the European S3 guidelines, and we do measure an objective assessment of of disease severity. That is why we are talking about the global assessment, not just BSA. We are talking about the PASI and also the health-related quality of life. So DLQI is one method. There is a more important one which is called HRQOL, and that looks at the impact on physical, psychological, and social well-being. So the social well-being is not very well covered in DLQI alone. So this is a slightly more expanded measure. You should measure this at initial presentation and throughout the subsequent treatment, and make a note of that in your case sheets or in the prescription to know how the patient is improving. There are foundational management principles. Foundational means the basic management principle. The basic first important management principle is patient and community education. Disease awareness, self-care. We have to teach the patient it is their duty to be aware of the disease. It is their duty to be aware of how the disease is affecting them. What is the lifestyle management? What are the triggers? And as a doctor, as a dermatologist, you are responsible for clinical exam and diagnostic tools. We did speak about quality of life. There is physical and mental disability. This was it's an old paper actually by RAP. It was, I think, published in JAMA, if I'm not wrong. I can't read this very well. I forgot my glasses. If you look at this, chronic conditions with comparative or comparable reductions in the health-related quality of life, psoriasis, cancer, arthritis, hypertension, heart disease, diabetes, depression are all on the same par. In the same paper, actually, RAP also mentions that the second most important cause of suicide is psoriasis after cancer. I think we should think of that before we prescribe drugs. So a holistic approach is urgently needed in India. You have to address all physical symptoms and sign, and also the psychological disease like anxiety and depression. When a psoriasis patient walks into a room and appears to be obviously stressed out, he's not angry with you. He's angry or upset that he has the disease. So spend a little more time with the patient. You have to manage the lifestyle. Identify the triggers like stress, infection, smoking, alcohol. Explain Kobna's phenomenon to them and skin injury, because you can really prevent psoriasis from spreading if this is explained to the patient. Please address the comorbidities. Do a complete assessment. It is linked to heart. Avoid stress. That cannot be done. But promote relaxation techniques like meditation, yoga. Now, most times people scoff at meditation and yoga. But I would say that if you can tell your patient to exercise, that itself is a good stress management technique. So that's what I tell my patients. In the treatment modalities, we have topical, systemic, and phototherapy. Phototherapy includes UVB, UVA, and PUVA. I am stressing on this. I'm focusing on this because this is what is very practical in India. And when you look at how you have a step-ladder approach to handling psoriasis, there are topicals, there is phototherapy, then you can introduce oral drugs, and then you can go into injectable biologicals. Most times, injectable biologicals are completely out of reach for Indian patients. I think that less than 5 to 10% of patients with psoriasis in India actually have access to biologicals. So I do work a lot on biologicals, but I'm aware that you have to look at overall disease rather than just biologicals. The severity of disease guides a selection to treatment modalities. We listed out all the modalities. The plaque psoriasis, look for symptoms and signs of arthritis. It's extremely important because arthritis will disable the patient. Look at if it is so, go straight into systemic pharmacotherapy with or without phototherapy to manage the skin. If there is no arthritis and if the disease is mild, topicals with phototherapy is very effective in Indian patients. If it is moderate to severe, you might need systemic therapy. And in systemic therapy, we have several choices. The American Academy of Dermatology has its own recommendations to psoriasis management. Once again, they very clearly say if there is arthritis, you need systemic therapy immediately. Topicals are not good at all. If there is no arthritis, classify it as limited and extensive disease. Limited disease, once again, topicals or targeted phototherapy is the most practical in India. Extensive disease also, you have phototherapy and oral systemics that are effective in India. Biologics, as I said, are not a very practical option in India because it's an expensive option, but worth it. And you can use it intermittently for side effects, especially when you are using a topical steroid for your patient. Look at cost-effective topical therapies. I find that emollients are highly effective to prevent severity of disease and also to try and prevent relapse. It soothes the skin, it relieves itching, it softens the scales, thereby making topical therapy more effective. Accessibility, it's widely available and affordable, it enhances absorption of topical medications. One of the most important topical emollient that we have in India is liquid paraffin. And in other patients, they will even discuss simple coconut oil. I don't think there is anything emphatic about telling your patients go ahead and use it. We are looking at a resource poor setting. Coal is also inexpensive. The only problem here is it has a pungent odor and sting, but cost effectiveness makes it a very valuable option. It is effective especially for scalp, palmoplantar psoriasis, and plaque psoriasis. Salicylic acid lowers the pH of the stratum corneum, therefore scales come out faster, which is what troubles the patient a lot. You can combine it with topical steroids. There are commercial prescriptions for this, and it's a good option. Corticosteroids are anti-inflammatory, but please remember that it has to be short-term usage. Don't tell your patient mix it with the moisturizer and apply it all over the body. I've seen this prescription very often in my practice because this mixture is not tenable. We'll talk about it if you want in the discussion time. So we have topical steroids. The disadvantage are local skin effects, systemic absorption. Glaucoma can worsen using topical steroid. Short term, there's a rebound flare, pregnancy category C. Vitamin D analogs are unfortunately expensive. Calcipotriol is available in India. Decalcitrol is not available, but calcipotriol is. It's very effective in scalp psoriasis. In other areas, I don't think it is such a big deal. I don't use it at least. Tazarotene is available. I use it mainly on the nails. I don't use it on the skin because it has a high irritancy potential. A lot of this, by the way, may appear to be too simplistic because everybody does the same thing, but this is part of the schedule that we have chosen today because we don't want to forget basics. So we're going to be a very basic lecture. Calcineurin inhibitors like tacrolimus and pimecrolimus, they're quite effective in the folds of the body. So it should be considered an option. Maybe you want to mix and match TCIs with topical corticosteroids. There is a point here which we have taken from the literature saying potential risk of malignancy. It is there in the literature. All TCIs have a black box warning, but I would say that ignore it. It is nonsense and has been scientifically disproven. Non-medicated moisturizers like occlusive agents, humectants, emollients are internationally accepted standard adjunctive therapeutic approach. We spoke about salicylic acid. We used to use anthralin very often. We used to use it especially on the palms because thick scales, it's a very good option. The only problem is it stains the clothes permanently and the skin temporarily. It's not suitable for the face. Coal tar, we've already spoken about, whether it is the Ingram or Guckerman regimen. There are phototherapy options. The best here is natural sunlight, UVB phototherapy if you have access to it, and it requires close medical supervision. These are phototherapy chambers, and treatment is usually administered 2 or 3 times a week, and I think this is a very good option. This is a good option here in our country. When you come to systemic therapies, it is mainly reserved for widespread and severe psoriasis. The indications are PASI more than 10 and if there is a severe impact on quality of life. Methotrexate is probably the most common systemic option that we have. It's a standard treatment for severe psoriasis. Acitretin is also used, especially for the palms, soles, and the scalp. Both require strict monitoring, blood counts, liver enzymes. This is important here. The traditional systemic options, we also have cyclosporin, which is used for crisis or pustular psoriasis or erythrodermic psoriasis. After that, you can transit to methotrexate or acitretin or some of the other systemic options we'll discuss. A major problem with cyclosporin is nephrotoxicity, so don't use it continuously. I have seen doctors and speakers speaking about cyclosporin for 2 years and 3 years. I think that should be avoided. Methotrexate can produce pancytopenia, and that can be life-threatening. Acitretin is a useful retinoid. You can combine it with PUVA. You can combine it with phototherapy. It is not immunosuppressive, so especially in HIV patients or patients who are on other immunosuppressives, acitretin is a very good option. But there could be mucocutaneous effects like scaling, chapping, ulcers, hair loss that can happen. We use it only at 10 to 25 milligram per day, and we all know that if you use acitretin, give a 3-year gap because of the teratogenic potential if a woman is planning pregnancy. Apremilast is an oral small molecule inhibitor of phosphodiesterase 4. If you inhibit PDE4, there is a concentration of cyclic AMP inside the cell, which prevents inflammasomes from secreting cytokines. This is a useful option because even though it's a very mild immunosuppressive, it can be given for all types of psoriasis. It downregulates TNF-alpha, IL-17 and IL-23. You can even use it in combination with this. It upregulates IL-10. Incidentally, since it's not a very detailed lecture, when you upregulate IL-10, that's what is done in phototherapy. In India, it is useful because it is inexpensive. There is no end organ damage. Blood count monitoring is not required. I prescribe it for 6 months at a time. Side effects are easily managed. We'll talk about the side effects. Mainly useful for mild to moderate psoriasis, but I use it even for severe psoriasis patients who cannot afford expensive treatment or follow up regularly. It can be combined with other conventional and biologic therapies to maintain a response. The most common problem you have with apremilast is GI side effects. Now, these GI side effects are very easy to manage, provided patients have what is called as gastrointestinal hurry. You step up the dose. Map is also available with us, and you can also use IL-17A. Inhibitors like secukinumab or ixekizumab or bimekizumab. All of them are there. We have it. We have access. But these are, I think, very expensive drugs for India. I have mentioned this, and many patients, even of mine, who are using these drugs, I find the dropout rate is very fast, and the psoriasis comes back. So after about 4-5 months, they tend to drop out. So it's a bit difficult to maintain a patient on a biologic. So that's a big problem. One of the major problems with the biologic, especially with TNF inhibitors, is congestive heart failure and demyelinating diseases. IL-17, we are only concerned about probable worsening of IBD and candidiasis. And patient education is important. We don't have that in India. So empower your patient, improve adherence, utilize support systems. We don't have support systems in India, but we will be getting one very soon in the next 2-3 months, and all of you can make use of that. In case management, to repeat, do an initial evaluation, go to a stepwise approach, maintain monitoring and continuation of care. You can leverage modern solutions and community care. Telemedicine is useful for this. Your patients can be monitored through telemedicine, so it decreases the need for access to regular monitoring, so brings down cost. Community health worker model, once again, you have to reach out to community health workers. Support groups are required. As of now, we don't have, but in 2-3 months, we will be getting it. There is a call to action. You have to have a change in policy from the government to empower patients to get more expensive drugs. You have to strengthen local capacity. You invest in training for dermatologists. Many dermatologists are not yet comfortable treating a psoriasis patient. Expand the telehealth infrastructure, foster global partnerships. We should have more Indian dermatologists in international societies, and focus on patient empowerment. Patient groups should come in. In conclusion, an effective management of psoriasis in resource-poor settings requires a multi-pronged strategy. Prioritize cost-effective and accessible treatment like emollients, topical corticosteroids, and a rational use of methotrexate. Emphasize patient education, lifestyle modification. Make sure you give your patients a target each time he comes, and make sure you go through that again. Stress management. Promote awareness to avoid social stigma and improve quality of life, and advocate for improved access and reduced costs for conventional treatments in low income areas. I think this is the more important part of the entire discussion today. With that, I conclude, and if there is time, Dr. Pallavi, we can take questions. Otherwise, we'll do it. Okay? Thank you very much. Somebody get it? Okay.
Thank you so much, sir, for your insightful presentation. Now, moving forward in our today's program, I would like to introduce our today's one more faculty. She is an international speaker, Dr. Jennifer Soung.
Wonderful. Hi, everyone. Can you hear me okay?
Good evening, ma'am.
Good evening.
So,
Can
Dr.
you hear me
Jennifer
okay?
Soung.
Hi. Can you hear me? Can you hear me? Hi, everyone. Namaste from
I
California.
can't hear her.
Should we check the audio again?
Check. Ma'am, we can hear you from Delhi.
Okay. Wonderful. Can you hear me now?
Yes.
Wonderful. Namaste from California. It is such a pleasure to join my dermatology colleagues in India.
But we are not able to hear him. उसको बोला
Shall I call them? Okay? Excuse me. Ma'am, can you say something so we can hear you?
Sure. Namaste from California.
Namaste, ma'am. How are you?
I'm doing great. So
Okay.
it sounds like it's working now.
Thank you for joining us today. And let me introduce Dr. Jennifer Song. She is a renowned dermatologist and clinical research, and she is based in California, USA. She has contributed to numerous publications in dermatology and has
the mic. Palvi, we can't hear you in Delhi. Hello? Palvi, we can't hear
Hi,
you in Delhi.
uh, are they able? Are you
Yeah,
able to hear now?
we can
Yes,
hear
ma'am.
you
Yes, ma'am.
now in Delhi.
Yes,
Okay.
Pallavi, we can hear you.
Okay. Thank you so much for heads up. Okay, so Dr. Song is widely recognized for her contribution to clinical and academic research. She is in academic and also is associated with clinical researches, and she continues to be an influential voice in advancing dermatology care globally. I welcome Dr. Song. We are delighted to have you with us today. So I will give over to Dr. Song to start with her presentation.
wonderful. Thank you so much. It's such a pleasure to join you all, my dermatology colleagues in India. Though I wish we could meet in person over chai instead of over the screen.
Yes, ma'am, sure.
So psoriasis is one of those conditions that reminds us that skin is never just skin. Underneath the surface is immune dysregulation and systemic inflammation. So today we're going to explore how understanding the pathophysiology of psoriasis and comorbidities have really transformed the way we treat not just skin, but the whole patient. So give me 1 second while I share my screen and my slides. Wonderful. So let's get started here. Let me just minimize. Sorry, one more thing on my screen so I can see the entire screen. Okay, I think that'll be okay. Okay, so let's get started. This is our table of contents. So in the next approximately half hour, we're going to start with the basics of psoriasis, go through the pathophysiology, more importantly, talk about the comorbidities and the domino effect of psoriasis, and then conclude with current management strategies and future perspectives in research. What is psoriasis? Psoriasis is a chronic autoimmune disease of the skin where inflammation can extend beyond the skin to affect the joints. What we see clinically on the outside is a thick, red, well-demarcated plaque with this classic scale. I think many patients come to us in dermatology and they're often confused, maybe given a diagnosis of psoriasis or eczema. And often it requires a trained physician, a dermatologist, to make that diagnosis. Usually it's clinical. In some tricky situations where it may not look classic, then a biopsy might be warranted. Global prevalence of psoriasis is around 2 to 3% higher in certain Western countries and possibly lower in Asia and Africa, although I wonder sometimes if it's just underreported. Psoriasis in India is anywhere between 0.4 up to almost 3%. Peaks in the 30s and 40s with men twice as affected. Let's review the different subtypes of psoriasis. I will say these days, plaque psoriasis, with all the different treatment options we have, generally is quite easy to treat. These days now, with all the different options that we have, from topicals to orals to biologics, I would say most of the time, 90% of the time, we can get our psoriasis patients pretty clear. So I tell my residents, if your patient is on a highly effective biologic, or even specifically highly effective biologics, if they're not clear, we should definitely revisit the diagnosis. Now, there are other subtypes of psoriasis. For example, inverse psoriasis, where it affects the folds of the body, and that's underarms, breasts, even in the private area, and especially the gluteal fold. Sometimes that area of psoriasis is hidden, and the patient isn't even aware that they have a plaque or a patch there. So when a patient is referred from a rheumatologist for a possible diagnosis of arthritis and wondering if the patient could potentially have psoriatic arthritis, I look in these hidden areas behind the ear, in the scalp, or the belly button, or the gluteal fold for clues for psoriasis. Gut-tape psoriasis is a unique form where the patches aren't so thick and they're thinner, often associated with a infection like strep throat, and comes on a little more suddenly. And these patches are much thinner. Often the patches can resolve, the episode can resolve, and in certain patients can evolve to plaque psoriasis. We also have other forms like pustular psoriasis, which can be localized to hands and feet, or in other certain situations, more widespread. So that can be a little tricky because it can often look potentially like an infection to the untrained eye. And in these situations, patients can sometimes present with fever and more acute symptoms, similar to erythrodermic. So these are the two situations where psoriasis might be more of an urgent situation, with widespread pustular psoriasis, as well as erythrodermic psoriasis, where this is a little more rare, but definitely I have had firsthand experience with many cases at the academic hospital, as well as where I practice in California. It is widespread with diffuse redness, and the entire skin is shedding with severe itch, often fever as well, and can potentially be life-threatening. Most of the time these days, if a patient does come to my office nearly erythrodermic, we have many treatments that can really help the patient quickly. Not only oral medications like cyclosporin, but also some of our highly effective biologics like the IL-17s can work really quickly to help these patients. I probably should have started to explain first that I work in a part of Southern California, south of Los Angeles, called Orange County. And the office and my research center is located in an underserved area. So I see a very diverse patient population, diverse in socioeconomic status, so many underserved or underinsured patients, as well as privately insured patients, as well as a diverse population of patients in racial ethnic background, as well as diverse skin tones. So everything from Asian to Southeast Asian, Middle Eastern, as well as Black patients, and then white patients and Hispanic patients. In fact, I am an American-born Chinese American, and I speak quite fluently Spanish because I studied a little bit in Spain and grew up in the US. So very useful to speak Spanish, and because of my family heritage, I speak a little bit of Mandarin Chinese. That is kindergarten level, but I've found that both of these languages have been very useful in speaking to my patients living in Southern California. So moving on to the pathophysiology of psoriasis, certainly in the last 20 years, with the revolution of new treatments for psoriasis, we have learned to target the inflammation in psoriasis in a much more specific way. So when I talk to my patients about what is the cause of psoriasis, it's certainly a complex autoimmune disease that has both genetic factors as well as environmental triggers. So you see number 1 and 2 being components of that pathophysiology, a predisposition based on genetics, and then as well as some sort of environmental trigger. So we know strep throat infection can play a role, Any sort of trauma or intense stress can modulate that immune system. Even certain medications can trigger or unmask psoriasis. Once the immune system has been triggered, often detected by those dendritic cells, then the T cells get activated. And so now we know that probably one of the most important players in the T cells are actually Th17 cells. And you see that the Th17 in this image here plays that central role and then subsequently produces many inflammatory cytokines that then stimulate the keratinocytes to produce a thick, well-demarcated plaque. And so many of the pharmacologic agents that we have target some of these key cytokines in this pathway. So you're familiar with TNF-alpha and IL-17, as well as IL-23. And so you can see that there's a cycle here of inflammation, which is centered based on the immune cells. So the discovery that psoriasis is really an autoimmune disease that is triggered, that results from overproduction of cytokines, has really helped us develop new treatments for psoriasis that are really highly effective. Now, the inflammation in psoriasis isn't just in the skin. Many of our patients who come to see us in dermatology, their primary complaint is the skin. However, upon meeting the patient and asking more questions, and especially one of my first questions before you can decide on treatment is really, do you have any signs or symptoms of psoriatic arthritis? That is probably one of the most important comorbidities here. This slide talks about the cardiovascular component. I start with joints because about 30% of our patients have joint involvement. On top of that, these patients, more than 50% can have a comorbid metabolic syndrome. So here you can see cardiovascular disease is really emphasized with a linear relationship. If you look at the bar graph below, you can see that with more severe psoriasis, mild compared to severe, you have an increase of cardiovascular risk. So whether it's myocardial infarction, stroke, or overall cardiovascular mortality is increased in our psoriasis patients. Now, it's probably due to a combination of things. The metabolic syndrome, as well as an increased risk of obesity, all contribute, and as well as the chronic inflammatory state of psoriasis. So that's why the patients who have more severe psoriasis have a higher inflammatory burden. In fact, the American Heart Association uses psoriasis as one of the factors to level up their cardiovascular risk. So if the patient is on borderline, then you would be slightly more aggressive in terms of treating their cardiovascular disease. So you can see here the systemic inflammation comes not only from the cytokines, but the metabolic syndrome, perhaps also lifestyle as well. So what does that mean in my clinical practice? So I often screen patients, especially when I'm going to be the one that's starting some sort of systemic therapies, whether it's oral or biologics. I really believe in treating the patient in a comprehensive way. So when I'm getting my labs, I'm checking not only for the CBC or the blood count, the comprehensive metabolic panel, which will include LFTs, hepatitis serologies, but I'm also checking a hemoglobin A1C to check for diabetes, and I'm also checking a fasting lipid panel. And so I really think that treating not only the skin, but the entire patient will help with managing a truly systemic disease like psoriatic in these psoriatic patients. You can also see at the bottom of the bar graph, the myocardial incidence also increases in our patients with mild and severe psoriasis. Beyond going further, kind of delving into the metabolic syndrome, you can see here that patients are 2 times higher of having metabolic syndrome, along with the chronic inflammation. This topic here in the US right now is a very hot topic because GLP agonists, which have changed weight management for treating obesity in the US, has really shown that with significant weight loss, we're talking about more than 10% of the patient's weight can result in resolution or improvement of cardiometabolic markers like hypertension, high cholesterol, as well as diabetes. And so in patients who have psoriasis, we're looking now at treating psoriasis patients not only for their skin, but also the inflammation that comes with the obesity using GLPs. So screening again for these metabolic diseases is really important. Beyond the cardiovascular risk and metabolic syndrome, you know firsthand by treating these patients that there's a higher risk of depression and anxiety. Patients tell me firsthand how much it impacts their life. That's probably one of my key questions when I'm getting to assessing the severity of their disease, besides knowing what treatments they tried before, whether it's topicals or maybe other orals or light therapy. I also want to know how it impacts their life so we can decide together what's the best treatment. So these skin lesions because it's so visible, result in low self-esteem and anxiety and depression. And so many times we as dermatologists have the potential to give these patients hope and also really transform their lives. Okay. Now, psoriasis patients have other comorbidities like hepatic complications, so increased risk, 2 to 3 times risk of fatty liver disease. So in situations where we are using methotrexate and cyclosporin, I am monitoring their liver function tests closely, as well as renal function. And in certain situations, some patients also have higher risk of chronic kidney disease. So monitoring the oral medications is really important. Other autoimmune conditions, I touched upon psoriatic arthritis. I do want to emphasize, because the majority of the time, probably 75% of the time, psoriatic patients will present with skin lesions first before the arthritis. So as dermatologists, we're in a key position to kind of minimize or kind of stop that domino effect, which is we're going to treat patients and screen them earlier for psoriatic arthritis. A third of our patients with psoriasis skin lesions can have arthritis. And so I personally like to use the PES questionnaire in my clinic. I use it for myself. I'm not actually giving the questionnaire to the patients, but in my mind, I'm thinking, during my physical exam, do you have any evidence of nail involvement? So during the physical exam, I'll check their nails. I'll also look at their fingers and see if any of them are swollen like sausage digits, or I'll palpate the Achilles tendon to check for any sort of tendinitis there. And then I'll also ask them if they have joint pains in general or any sort of back pain that wakes them up in the middle of the night. And then finally, in the history, I find that morning stiffness is a key differentiator in the clinical history of an inflammatory arthritis versus osteoarthritis, which is usually at the end of the day. So when patients wake up in the morning after a night of rest, when they have stiffness, that is highly suggestive of an inflammatory arthritis. If they have psoriasis lesions, then that makes the diagnosis of psoriatic arthritis. So I think that in dermatology, we'll be screening using the PES questionnaire. It has high sensitivity for screening for psoriatic arthritis. We'll probably be treating these patients earlier. And so in the future, again, that domino effect, less patients with active psoriatic arthritis or debilitating psoriatic arthritis. In a small set of patients, some patients will present with both IBD and psoriasis. Other autoimmune diseases certainly are potential. So I alluded to this domino effect of chronic inflammation. And so let me this is covering part of my slides here. Okay, perfect. And so you can see multiple effects of chronic inflammation. And this is why right now in the US, the inflammation coming from obesity is a very hot topic. For years, we have known, prior to the invention of GLP medications or these weight loss medications, that obesity plays a role in contributing to that cycle of inflammation. That fat cells are also contributing cytokines like adipokines and contribute to the inflammation of psoriasis. In fact, small studies in patients who've had dramatic weight loss show improvement in their skin scores. just by losing weight. So we've talked about the cardiovascular risk, the metabolic syndrome, the obesity, the liver involvement. So this is all the effect from the chronic inflammation. So these shared pathways of inflammation, whether the inflammation is contributing to the cardiovascular disease or coming from the obesity, it's I think of it as like a big soup of different cytokines that can have systemic implications. So you see here, all the way on the right, you can see because of these shared pathways of inflammation, along with the risk factors, you have cardiovascular disease, metabolic syndrome, fatty liver disease, psoriatic arthritis, chronic kidney disease, and depression and anxiety. So again, this is really not just about skin. When we're treating our plaque psoriasis patients, it really goes beyond that. So on that first visit, when you meet your psoriasis patient, there's a lot of things to cover. So again, a couple of my favorite questions is one, how does this impact you and what are your treatment goals? And that gets quickly finding out where you and your patient are going to partner. So in terms of talking about quality of life, these patients have a physical burden, that flaky, itchy, sometimes painful skin. In patients who have psoriatic arthritis, they also have the pain and stiffness from the joints. In fact, many of the patients don't even realize that the pain and stiffness in their joints is related to their skin. And often once you start systemic therapy, the patients are surprised that they're feeling so much better. So along with the improvements in skin and joints, you also improve their self-esteem and then increase their productivity. And ultimately, I tell my patients what I want to do is help them live their best life. So in this last section, I'm going to summarize current management strategies. I know you guys, we just heard a talk on covering some treatments for psoriasis. I'm going to review briefly oral systemic agents like cyclosporin. I still find useful in my practice. And it's often used in patients who have severe psoriasis where I want to rapidly gain control. And so it's great for short-term therapy. And I monitor the kidneys and hypertension. So again, very effective as a rescue option. Methotrexate, I still use it. Here you can see first-line cost-effective treatment. And I do monitor, similar here, every 3 months. I'm also monitoring and keep track of cumulative doses as well. And I think sometimes there is some GI tolerability issues, and certainly we avoid this in any active liver disease, pregnancy, or any severe renal impairment. So earlier I heard you were all talking about apremilast, and it is indicated for moderate to severe psoriasis and psoriatic arthritis. We have great data in nail, scalp, palmoplantar disease. And it makes it easy to prescribe because there's no routine laboratory monitoring that's required. The only situation to remember is a dose adjustment in patients who have severe renal impairment. Usually we don't see that many patients in our dermatology clinics who have severe renal impairment. So often preferred in patients who can't use an immunosuppressant. It can be an excellent option for long-term maintenance. Topical therapies are certainly often our first line in our mild to moderate patients. So topical steroids are the foundation of topical therapy. Then additional, perhaps vitamin D derivatives or even topical calcineurin inhibitors in that sensitive skin area, ideal for the face or the inverse areas. And then keratolytics to help break down that thick scale. Sometimes I'll use a keratolytic at one time of the day, for example, in the morning, and then use their high potency topical steroid at the other time so you get better penetration. And moving on, so you can use combination topical therapy as well, so vitamin D with a high potency steroid. Certainly, you all in dermatology, or we, are the experts in the art of topical therapy. So we know that the vehicle is very important when we're considering special areas like the scalp. You'll want to use solutions and foams. Face and flexural areas, we want to be more gentle. We want to minimize any atrophy or striae, so we use topical calcineurin inhibitors, and then thicker plaques really require that combination of steroids and keratolytics. And so here you can see for long-term adherence is really having a routine of topical therapy without increasing risk for side effects. Newer therapies have given us really so many more tools for our patients who have more severe disease, so in that moderate to severe category. You can see here the history and different classes of biologics over the years. And I've been studying biologics for psoriasis for the last 20 years, ever since the first biologic was invented when I was in medical school. And that's no longer even on the market. It used to be called Amiviv, and it targeted T cells. So our major categories of biologics include TNF alpha inhibitors. I kind of think of them as my first generation, including ustekinumab, which is the 12 and 23 target. And our latest generation or class of biologics are really the IL-17s and IL-23. So in my personal practice in the US for biologics, I've really moved on to 17s and 23s and only use TNF inhibitors reserved in situations where patients have multiple comorbidities, for example, IBD and psoriasis, or ankylosing spondylitis and psoriasis. The next generation systemics, we talked about apremilast, and then the newest is deucravacitinib, which is a TYK2 inhibitor, so which has some nice efficacy as well as good safety. Biosimilars are here, especially for TNFs. They've already been here. So really the clinical takeaway is that many of these therapies have really changed the way we care for our psoriasis patients, allowing for high efficacy, sustained remission, and improved safety. I really wish biologics were a little less expensive so that more patients could be treated. So when we talk about current management strategies, I also talk about lifestyle interventions. So that healthy weight, the diet, regular exercise, and then in terms of managing comorbidities. So in my personal practice, I encourage patients to see their primary care to screen for their comorbidities. In certain situations where they don't have a primary care, I will step in and help out. So let's briefly look at some future perspectives. Here you can see there's continued research into the next generation of biologics. So we have dual IL-17A/F inhibitors. In fact, bimekizumab is already available in the US. And then we have some other IL-23P19 inhibitors. Some studies are looking at giving super high doses of IL-23 to essentially knock out the inflammation. There are subsequent generations of more TYK2 inhibitors and even oral IL-23 and IL-17. Biosimilars are here, and more research into also other new innovative ways of targeting inflammation. So certainly with many choices that we have, we can individualize care for our patients. Although these days when I'm educating about psoriasis, I tell dermatologists, you don't need to know every single biologic or oral medication. I choose one from each class, or narrow it down for your patient to 2 choices. So in terms of future perspectives, when selecting agents for the skin, we want to minimize systemic risk and reduce cardiometabolic inflammation. So you can see here, our IL-23s have high efficacy, excellent safety, and can address some of that inflammation in the metabolic condition with these patients. Similar to IL-17s, rapid clearance. I would probably not choose this first in any patient with active IBD. So in my personal practice, the 23s and the 17s are really my top 2 choices for treating plaque psoriasis here in the US. Now, in oral medications, we have deucravacitinib and apremilast, and these days I'm using much less TNF inhibitors. So let's look at one of the clinical studies, which is apremilast in moderate to severe plaque psoriasis patients, specifically the LIBERATE study. So this was a phase 3 randomized double-blind placebo-controlled study for 52 weeks. And so they had 3 arms: apremilast 30 milligrams twice daily, etanercept 50 milligrams once weekly, and placebo. These were 250 bio-naive adults with moderate to severe plaque psoriasis. So basically, for the first 16 weeks, they were either in apremilast, etanercept, or placebo. Then everybody transitioned to apremilast 30 milligrams BID. Etanercept was an active comparator. So they showed that the transition of patients from etanercept to apremilast allowed maintenance of their response. So almost, I believe it was 50% of patients achieved a PASI 75 and on their initial group. And so even in the group of patients with etanercept, they were able to maintain clearance with transitioning from etanercept for the first 16 weeks, then to apremilast. When we look at safety, it was well tolerated, just a little bit nausea, diarrhea, not unexpected for apremilast, and no new safety issues up to 52 weeks. Again, no laboratory monitoring required, mild and non-significant weight loss. So here you have the data here. So I was close. The PASI 75 at week 16 for apremilast was 40%, and then etanercept almost 50%. And you can see that the PASI 75 at week 52 on apremilast was maintained in the 47 to 53% range. There was a rapid onset with improvement in itch and pain by week 2. Really, the key point here is sustained and durable response even after switching from etanercept to apremilast. So benefits are apremilast is effective, well tolerated, a convenient oral alternative to biologics. And we saw that the transition from etanercept to apremilast was well tolerated with efficacy maintained. So in conclusion, apremilast offers a safe, sustained, and convenient oral therapy for bio-naive patients with moderate to severe psoriasis, improving both the itch, skin, and quality of life over 52 weeks. So I know I am pushing against time here, and we're going to wrap up here. So again, looking at the comparative advantages of apremilast, you see minimal liver toxicity, great tolerability. Besides the short-term GI effects, we heard from our prior esteemed physician that titrating longer can minimize those GI side effects. And it's convenient with oral dosing, no lab tests, safe in liver disease, and women of childbearing potential. Earlier, I summarized some of the traditional treatments that have concerns with hepatotoxicity monitoring, as well as nephrotoxicity. So you see that here summarized. So that brings us to our last slide. So thank you so much for your time and attention. And I believe we're now moving on to the panel, and we can take questions during the panel discussion.
Thank you, Dr. Soung, for your impactful and wonderful presentation.
You're welcome. It's a pleasure to be here.
Okay, so now I'm delighted to welcome. Now I am delighted to welcome our two esteemed and renowned doctors, dermatologists. One is Dr. S.G. Parasramani, who is connecting from Mumbai, and Dr. Sanjeev Kandhari, who is connecting from Delhi. I welcome both of you. Dr. S.G. Parasramani is a highly respected dermatologist and laser surgeon with over 4 decades of experience. He practices currently at Lilavati Hospital, Mumbai, and has made remarkable contributions through research, publications, and clinical excellence. I am delighted to introduce Dr. Sanjeev Kandhari, who is a distinguished dermatovenerologist and leprologist with more than 43 years of experience in teaching and practice. He has held leadership roles in National Dermatology Associations, authored books and chapters, and delivered lectures worldwide. I welcome both of you. Thank you for joining with us virtually. Okay, so now I request all of you to join us in the next segment, that is panel discussion, a very engaging and important part. So let's begin with a panel discussion. Okay, so I invite Dr. Murlidhar to the stage, Dr. Soung, and Dr. Sanjeev Kandhari and Dr. Parasramani. Okay.
Thank you very much, Dr. Pallavi. And Dr. Song, I can't see you, but I'm very grateful that you spared time to be with us. What I can see is a full hall. So I guess you can understand the interest that your presence has evoked here. It's good to see you again. Thank you. I'm very grateful that my friends, Dr. Sanjeev Kandhari and Dr. Parasramani, I've worked many times with them. We've had a lot of discussions, and three good friends, Dr. Soung, Dr. Kandhari and Dr. Parasramani, we'll be kicking off a panel discussion to a full audience here at Chennai. I'm very grateful to the audience. I find that most of the audience is a young audience, and this is the way to go. Youngsters have to take it up, and please feel free to give me your questions. We have exactly half an hour, and we have a lot of panel questions already decided. So I will request that all of us keep our discussion extremely brief, probably less than a minute. That will be the best way to go forward. So that it's more of a discussion, it's more of a chat. Let's just put it that way. I'll just throw open the first question. I think Dr. Song spoke a little bit about this, but I would I would request her to expand a bit on how systemic inflammation contributes to cardiovascular disease, diabetes, and other metabolic disorders. She did mention that there is inflammation and that these comorbidities occur. But what is the exact link? Dr. Song, could you just elaborate a little bit on this? Because this is important.
Absolutely. So we know that the inflammatory markers and cytokines like TNF, IL-23, are increased in psoriasis. So depending on the severity of the disease, we also know that there's a linear relationship. So the more severe the disease is, so for example, if you have higher PASI scores, then the inflammatory burden is higher. And so we've seen that these patients are at highest risk for having cardiovascular disease, whether it's MI and stroke. In fact, younger patients who have more severe or extensive psoriasis also have the highest cardiovascular risk. So it's really these inflammatory cytokines that tie the whole story, right? Whether the inflammation is coming from the skin or perhaps the metabolic syndrome that includes obesity as a chronic inflammatory state as well.
Soung, would it be right on my part to conclude or to summarize by saying that we can consider a psoriatic plaque immunologically similar to an atherosclerotic plaque?
Yes, that's a great analogy.
Thank you. The next question that we have to answer is that if we know that these comorbidities are there, do we have any biomarkers or clinical indicators which can help us predict onset of comorbidities? So anybody can take that up. My friends, Dr. Khandari, Dr. Parasramani, any of you can take it up. We have a patient of psoriasis walking into a clinic, and is there any way in which you can predict that this patient is going to land up with this comorbid condition? Do we have a biomarker?
Dr. Murli.
Yes, Dr. Parasraman.
Yeah, we can do a highly sensitive
Good afternoon.
CRP. Good afternoon, Dr. Murli and
Yeah.
Dr. Sanjeev Kandari. And we can do highly sensitive CRP, which will help us to determine the inflammatory as an inflammatory marker, because it's very difficult to have other inflammatory markers, but indirectly we can get these markers. We can't measure the IL-17 and obviously 23 levels, but we can do CRP levels, and that will help us. And even you do the lipid profile for your patients, those who have got, those who are obese or they have got any other lipid abnormalities, then we do lipid profile for all of them. And of course, complete cardiovascular evaluation, you can do a ECG, you can do even a CT angio if required, if you feel like, or a stress test, or so this is the way we can find out whether there's any presence of any other metabolic syndrome or cardiovascular disease, and we treat them and refer them to the physician or the cardiologist.
Thank you very much, sir. I think what Dr. Parasramani is stressing, we have so many young dermatologists, is that please don't assume that psoriasis is just a skin disease. Do a complete, thorough physical examination of your psoriasis patients. We may not be able to do CT angios in all patients, but nevertheless, a thorough physical exam and a basic biochemical exam for psoriasis patients is mandated. And one thing I would like to add from my side is when you're looking at clinical indicators, a waist-hip ratio would be very useful. And looking for enthesitis, especially just ask your patient to turn around and look at the ankles, and you will be able to see enthesitis. People can do ultrasounds and all that, but there are some markers which you can look at when you look at a patient with psoriasis in your OPD. Dr. Kandari, yes, please.
I often get HOMA-IR done
Yeah.
and a serum lipids done for these patients, and that's, I find, is a very useful marker.
Very true.
Besides, of course, what Dr. Parsimani said, CRP is a good marker. And
Great.
of course, lipids, HOMA-IR,
Yeah.
waist-hip ratio, these are good markers to, central obesity or adiposity. It does give you a good indication.
Dr. Kandari, thank you. We'll stay with you. You have examined your patient, you have found comorbid conditions. Do you experience a particular challenge in treat to target? Now, the treat to target concept is different from treating psoriasis blindly. Most of us are actually treating psoriasis blindly. But if you want to adopt a treat to target strategy in patients with multiple comorbidities, do you have any challenge that you face? I will start with Dr. Khandari. He was just speaking.
Murli, in fact, there's a question which we remember we had discussed this when we had this conference in Jaipur.
Yes.
In which should each patient be taken up, we hit early and we hit hard in all patients or not? This was the question which we had discussed, and most people from all over the world felt that we must hit hard, hit early in all patients, because all patients basically are a process is going on in which the inflammation keeps on increasing in psoriasis. So I also believe in that. I mean, if we can hit hard and hit early, it minimizes so many things which are to follow.
I think I think you're right, Dr. Kandari, it will help us a lot, but we are going to have
Barring
a
the cost, of course.
exactly. So
and
we are going to have to discuss that a little more detail later on. The issue here is that we actually know that this staggered approach to treatment for psoriasis needs to be changed. The problem is going to be there are challenges in implementing it, and not everybody can even do a HOMA IR in their patients. Now, we'll go to the next. I would like everybody to just weigh in on this, because we have people from different regions. And we'll start with Dr. Soung. Dr. Soung, how badly does psoriasis impact a patient's psychosocial well-being in your patients?
The impact is huge. I think that patients who come in and you've been talking about treating earlier, kind of hitting hard and early, is that what happens is that there's a lot of delay in care, or patients don't take their skin condition seriously because perhaps maybe friends and family or even other healthcare providers minimize it, telling patients it's just your skin. So now the inflammation has increased over time, affecting whether it's joints, increasing in surface area. So I find that the impact on their psychosocial is huge, where patients are not being able to, for example, study or sleep well. And this concept of, this is one of my favorite concepts, is cumulative life course impairment. So psoriasis isn't debilitating because of that one flare-up or just a couple lesions. It's the accumulation of time over and over. So it's the physical burden of the itching and pain and flaking on top of the mental health burden. In fact, in some patients where they have recurrent or persistent disease, it may affect, for example, many young adults in their 20s to 30s, where the most common age psoriasis presents, is that now it affects their ability to study or finish college or university. It may affect their ability to want to socialize and date. So they decide that they don't want to get married. So you can see that in these situations, you can really change a patient's life trajectory or their path by treating their psoriasis, not only for their mental health, their social circumstances in health, but also that cardiovascular inflammation that we're talking about, that domino effect.
Thank you very much, Dr.
Point,
Soung. Yeah, I will just come to you directly, Dr. Kandari, again. Dr. Kandari, you present the Indian viewpoint. In your patients, how do you address the stigma and emotional burden? In your patients, what do you do? There are many people listening to you.
I think for me, the most important thing is, as I am understanding the comorbidities involvement, I counsel a lot. And I have so many examples in which I have counseled. The patients have lost weight, they've started a well-being program, and they've been able to come off the drugs which they've been used to for last so many years. So that's one thing. Another aspect, while Dr. Soung was mentioning, is the marital aspect. There's so many of my patients who find marital disharmony because of the look and the creams that they apply. It's very difficult for them to have a good marital harmony with their partner. So this leads to a lot of mental, problems and introversion and depression and suicides and everything, and also occupationally.
Dr. Sanjeev,
not
how do you
only in
address
adults,
this?
but also in children, especially if your hands and feet are involved. It's a great problem that you face in these patients.
Dr. Sanjeev, how do you handle it?
Well, besides counseling, as I said, many patients listen to me because of my seniority and they take it seriously and they start losing weight and they go on a well-being program. And you'll be surprised how many patients have just been off the drugs after losing 15, 20 kilograms of weight. It's an amazing thing. It was a revolution for me that happens. And I've also found these patients with, we've discussed one or two of them together, who have these fissures and things on the palms and soles. They respond very nicely to tofacitinib, which I've seen. And it's very, very rewarding to treat them with
Yeah.
tofacitinib, especially
So
if
sorry to
there's
interrupt you.
overlap between psoriasis and eczema at times, or there is blistering and fissuring of the palms and soles. These patients are really helped by this, irrespective
Yeah,
of the other drugs
I'll just
that
come
we
to
use.
that, Dr. Sanjeev. I'm going to take this to Dr. Parasramani. And Dr. Parasramani, how do you see children with psoriasis? What are the problems you find in children? Because I would think that emotional burden, stigma in schools is going to be probably more common in children.
You're quite,
Yeah, Dr.
yes,
Parasramani.
you're
Briefly.
quite right.
Yeah.
Small children are really affected a lot, and even the whole family gets disturbed. Once we tell them that your child has got psoriasis, it is very disturbing.
Yeah.
So we have to deal with this very carefully. We have to speak to the parents and we have to tell them that treatment is of essential value and the child has to receive treatment. And if required and we see that the disease is quite extensive, I do resort to using biologics in children because there are quite a number of biologics which are available apart from, of course, topical therapy or even phototherapy we can think of in. So these are the different methods by which I manage the children and of course counsel them and then tell them that of course the psoriasis is a disease which we cannot cure but we are able to control and put it under remission. But
Dr.
we can
Parasramani,
come
if
back.
if I may interrupt, I'm probably going to interrupt all of you in the interest of time. Dr. Parasramani, you have a child who comes to you with obesity. So there are two parts to this question. How do you manage obesity and psoriasis in a child? And the second, what's your opinion about apremilast in children?
Compared to, I'm talking of obesity, of course, it's a very essential feature. We have to talk to the parents and put them on the right, I would say, therapy. In fact, we tell them to go to the dietitian or you see that the diet is taken care of. But most of these small children, they are more on the carbs, especially in our country, the intake of carbs is very high. So we have to cut this down and then even ask them to increase activity. Many children, they just don't, they don't go to play. We'll see that they're always at home watching TV or they're on their mobile. So this is how we have to change the lifestyle pattern we have to change. Now coming to apremilast, I usually use apremilast about 12 years of age. I don't use in children younger than 12 years.
Okay. We'll go to the, there's something important about this obesity thing which I would like Dr. Soung to take up a little later. Dr. Soung, but staying with you, what is the current evidence linking psoriasis severity to increased cardiovascular risk? Meaning, do you think that more severe psoriasis is linked to more severe or incidence of increased cardiovascular risk? And if does it mean that your treatment of psoriasis patients will be changed on this basis? I hope my question is clear, Dr. Soung.
Absolutely, yes. So there's a linear relationship, meaning that the more severe and extensive the psoriasis, then the higher the cardiovascular risk. So when we're talking about the patients who are at highest risk for cardiovascular disease, it's really the patients who have the more extensive psoriasis involvement, those who have psoriatic arthritis, right, have the highest risk of cardiovascular risk on top of those patients who have the metabolic syndrome. So certainly there have been many studies in the last 10 to 15 years that have shown an association where if we treat the patients with systemic medication, we have the potential to decrease cardiovascular risk. In fact, in some of the medications, it has actually been shown to actually decrease the plaques, the atherosclerotic plaques. So cardiovascular diseases are much trickier. They need much larger clinical trials and longer time periods to follow these patients.
Dr. Soung,
But I think-
which drug, I'm very sorry, I'm going to give, we just want to get
It's okay.
some things into focus. Which drug do you think decreases cardiovascular risk?
Oh, wow. In terms of my opinion, I probably think our highly effective biologics or even our systemics overall can decrease inflammation. The question is to what extent? No one's been able to have direct causation. Similar to, some of you have shared that you have inspired patients to lose a lot of weight. And we know that weight loss alone will help with all of their comorbidities. So the cardiovascular disease, the metabolic syndrome, as well as the psoriasis.
What about methotrexate? Do you think it decreases the risk of cardiovascular disease?
Very interesting question you ask. I mean, our rheumatology colleagues have shown that methotrexate can decrease cardiovascular risk, also in rheumatoid arthritis as well.
Thank you. That's one thing I wanted to bring out. Simple drugs like methotrexate can make a difference. I'm going to stay with you, Dr. Soung, because you probably have direct experience with this. The GLP-1 agonists, how useful are they for psoriasis outcomes? Let's talk about psoriasis outcomes. And then we will take the opinion about cardiometabolic comorbidities. So what is your experience with GLP-1 agonists in psoriasis outcomes? Just psoriasis outcomes, that's it.
Great question. So there have only been small case series or case reports where patients with psoriasis have been given a GLP and no other psoriasis therapies, and then monitored to see if simply by losing weight with a GLP will that improve their psoriasis. So we're talking about just case reports. There's an ongoing larger clinical trial looking at Zepbound.
Yes. Sorry, I think Dr. Dheeraj, can you? I mean, it's frozen. Yep. Dr. Sanjeev, Dr. Parasramani is, the whole thing is frozen. I mean, anyway, for the audience over here, one of the first papers on GLP-1 agonists improving psoriasis, forget about cardiovascular risk, was published in New England Journal of Medicine about 4 years ago. It addressed the use of liraglutide, which is one of the first GLP-1 agonists. And a patient with diabetes was on liraglutide and no medication for psoriasis, and the patient improved and the psoriasis disappeared. After that, GLP-1 agonists have been investigated rather extensively. The drug which has been most extensively investigated for use in psoriasis is tirzepatide, and Dr. Soung was talking about it when we got frozen a bit. But yes, it is a completely different approach to therapy. Dr. Dheeraj, could we solve this, please? Yeah, sure. And as far as the cardiometabolic comorbidities are concerned, we must remember that GLP-1 agonists, now as far as, this drug, Victoza or liraglutide, is not available anymore. These guys from Glenmark have brought it as a generic here in India. So
you have been using risankizumab in US. Have you found any biologic failure with risankizumab?
Interestingly, the question was, have I found any biologic
Biologic
failures in
failure
using
with recent.
kizumab?
With Gucel, it has been reported. Biologic
Yes,
failure with
yes.
guselkumab, even with other drugs, but recent kizumab, I am not aware of.
Yeah, it's interesting. I do, maybe not complete failure, but yes, some patients do not respond to IL-23s as well, and then I'll switch them to IL-17s, and they are better IL-17 responders. However, I use both IL-17s and 23s, like risankizumab. They're both my top choices.
Okay, sorry, we got locked out for a while, Dr. Song and Dr. Sanjeev. Now, the next thing I would take is what about personalized medicine? Dr. Sanjeev, Dr. Parasramani, what are your opinions regarding personalized medicine? We have precision medicine already in play, but what about personalized medicine which addressed both psoriasis and comorbidities? What are your views? And then we'll take Dr. Song's expert opinion.
While you were cut off, I had mentioned my experience.
Yeah.
I often have given patients Munjaro mixed with methotrexate and found very good results. And
Okay.
many of my patients, I have now a series of them who've lost about 20 kgs and taken off alcohol, taken off non-vegetarian food and carbs, and they're almost off drugs. So I think it does make a major difference to do this.
Any other approach to personalized medicine, Dr. Parasramani? This Dr. Sanjeev has already mentioned when you are using a GLP-1.
You're quite right, Murli. When we examine the patients, apart from psoriasis, we have to look at comorbidities. Say if we find there's associated psoriatic arthritis, then you may think of using TNF alpha or secukinumab because that works well for psoriatic arthritis. And if you find a patient has got IBD, then obviously secukinumab and ixekizumab we will avoid. We'll use the IL-23 inhibitors. And now in India, we are having guselkumab and tildrakizumab available. So 2 IL-23 inhibitors are available. So we have to examine the patient and see what are the associated comorbidities. Suppose the liver is involved. And obviously methotrexate is something which we will be very careful, we may not use. Or if we find the lipid profile is affected, then cyclosporin is one which we may have to avoid, or if there is any renal involvement, then we will avoid cyclosporin. So like this, we have to examine the patient and then use drugs in a personalized manner.
You'll have to tailor treatment for each patient. And hopefully with the onset of better biomarkers, we will be able to have personalized medicine. One question to Dr. Soung, you will be having experience on this. How about when you in India we are using a lot of topicals? What is your view on topicals like tapinarof and roflumilast as a maintenance strategy for chronic plaque psoriasis? So could you expand on that, please?
Yeah, I have extensive experience using tapinarof and roflumilast topically as part of the investigator as the clinical trial So I think they're excellent options, especially being steroid sparing and appropriate and kind of something we were missing for many years.
Oh. I'm sorry. The audio visual should be corrected. Dr. Dheeraj, so why don't you just transfer to the Delhi team? Let them take it over. Yeah, just let them take over. Good. Can I go back and sit there?
Somebody's
for
asked, how do you
intertrial.
manage folliculitis with topinarol?
That's a great question. So the question is, how do you manage folliculitis in tapinarof? You actually have to stop the medication. So I've had extensive experience for patients. I've tried everything from your usual acne treatments. So whether it's topical clindamycin, oral antibiotics, and it really doesn't clear it up. So really temporarily discontinuing the medication is really the way to resolve it rather than adding more medication.
Yeah, similarly, in inverse psoriasis, I've often found that adding something topically like azole helps in these patients, especially on the scalp and the armpits and the groins. If you add azole to the antipsoriatic therapy locally, it does help. Just like in this, if you have a folliculitis, it becomes a problem. Similarly, in these patients, if you add this, it is a better response than otherwise.
Can you clarify, what do you mean by an azole, like a ketoconazole?
Yeah, ketoconazole or clotrimazole or any of these zoles that you add, or sertaconazole or mecanazole you add, it helps clear the lesions much better than just using an antipsoriatic drug.
I see.
In a combination.
Interesting.
That's a great tip.
Dr. Sanjeev, you think it's because of the anti-inflammatory effect of the azole?
It could be but I think, just like in other diseases, we have these agents, the infective agents acting as antigens, as a stimulus to the psoriasis. Maybe there is something going on that I've found that a combination always helps versus not. From that perspective, if
It's very
you
interesting.
look after in gutted psoriasis, you look after strep or staph infection, it helps the patient. Similarly, probably they are the ones which are triggering the process, and from that perspective, they also have an effect on the inflammation locally.
Thank you. Now, I would ask Dr. Parasramani and Dr. Sanjeev, but both of you are in metro cities. I'm also in a metro city, but I spoke a bit on therapeutic inertia. People take a very long time to come in for treatment. And even when you suggest a line of treatment for a psoriasis patients, they take a long time. They almost always say, we'll think about it, and they don't turn up after that. So what strategies would you recommend, and how do you manage for escalation to appropriate systemic or advanced therapies to improve long-term outcomes? What are your views? Anybody can take it up, Dr. Sanjeev or Dr. Parasramani. Because therapeutic inertia is not a problem in the West, but it is a problem here.
I think, barring counseling, there's not much that you can do, Murli.
Yeah.
You can only tell them. I mean, you can't force them.
I agree with you. Dr. Parasramani, do you use any particular technique? Do you tell them that if you don't take the treatment, you're going to develop a comorbid condition?
Yes, you're quite right. In fact, when the patients come to me and after diagnosing psoriasis, I tell them that there are certain other features like joint pains. If you do have joint pain, then you have psoriatic arthritis, or whether you have got some other physical ailments, metabolic syndrome, obesity. I talk to these patients and tell them that this is basically connected with psoriasis. It's not that these diseases are separate.
Yeah.
Psoriasis is now a systemic disease, and I tell them that they ought to treat all the metabolic syndrome or other systemic conditions also. So I tell the patient that only treating psoriasis is not going to help you. And we have to tell them, if you do not treat for psoriasis as
This
early
is
as
what's
possible,
going to happen.
going to land with a lot of other problems in near future.
I think that is an excellent point Dr. Parasramani has brought out. Dr. Sanjeev spoke about counseling. Dr. Parasramani brought out the fact that we need to explain to patients that you're not dealing with a skin disease, you're dealing with a systemic disease. They may not like it, but that's the importance of counseling. And that is what's going to ensure that the patients maintain therapy and actually take therapy properly. So that is a very interesting point. And once again, I'll go to Dr. Sanjeev now. How much do you focus on improving quality of life? Quality of life may not be affected in some of the more wealthy patients because they have other ways to compensate for it. But there are patients, I would say majority of patients in whom quality of life is seriously affected. We are going to wind up after one or two questions. Dr. Sanjeev?
I've stressed upon that, Murli, one or two times in this discussion only.
Yeah.
I spend a lot of time talking to them.
Yeah.
And, I suggest ways in which they can improve their quality of life. But cooperation after continuous counseling is essential from the patient, and his home environment also plays a
Sanjeev,
major role, and his own circumstances,
I think that's excellent.
where he's living and things like that.
Dr. Sanjeev, suppose there is...
And his own motivation.
Okay, now we
just
have...
like you keep telling these patients, you take adult vaccination when you're giving these patients, but many of them don't take it.
Correct. Now, if you have high impact disease,
I
does it
can't hear you,
change-
Murli.
Once again?
Now you're coming back,
Okay. If you have high impact disease, does it change your treatment strategy?
I usually believe in hitting hard and hitting early.
Yeah,
Now,
you mentioned that. Yeah.
I never used to do that, but I have started to do that,
Yeah.
honestly.
Okay, I will just take this to Dr. Soung so that this is the last question. We have to unfortunately conclude this. And once again, Dr. Soung, I'm sorry that your interaction with India, we have lost a bit of time due to blockages. Dr. Soung, do you think that if a patient has a comorbid condition, let's say a patient does not have psoriasis at all, but a patient is diabetic, a patient has dyslipidemia, a patient has metabolic syndrome. So do you think that these patients are more prone for psoriasis? And do you think that the presence of a metabolic syndrome or obesity is going to increase the risk of psoriasis? So I'm asking the question the other way around. Not that if you have psoriasis, will there be metabolic syndrome? I'm asking it the other way around.
You're absolutely right. The other way around is that more metabolic syndrome or more obesity, these patients are at higher risk of developing psoriasis.
That's a part of the psoriatic march, really, what we call. Obesity is a major part of the psoriatic march. So, that combined with genetic factors and environmental factors plays all a major role in the psoriatic march. So, you can't doubt this aspect that plays a major role.
But those who are genetically predisposed will get Murli. If they are not genetically predisposed, even if they have these systemic conditions, they will not get psoriasis. So
that's what I said, coupled with genetic factors.
That's important.
Dr. Sanjeev, you did bring in tofacitinib in this. One of the questions we've got from the audience is that
Again, we've lost you, Murli.
Lost,
I still have you. Do you have me now? No.
Well, Sanjeev, I have used tofacitinib.
All right. I think we should wind it up here because we have gone past 2. And Dr. Dheeraj, please convey my heartfelt gratitude to Dr. Soung. Please convey my gratitude to Dr. Sanjeev and to Dr. Parasramani for being there, because this cannot keep happening, right? We can't bob up and down. We have another meeting coming up. So I would like to thank everybody, and if this audience has any questions which you think I can address, please ask me right away. Otherwise, let's break for lunch. Yeah, both in atopic dermatitis and in psoriasis, vitamin D has been investigated. There are few studies talking about vitamin D, but you do not give it randomly if there is no deficiency. Vitamin D has been recognized as a good immunomodulator. It does seem to have some effect. One example we've seen is topical calcipotriol. So there is some effect, definitely. But there is no proven evidence that vitamin D alone, if you administer to your patient without anything else, is going to make a difference to your psoriasis patient. So deficiency is there, we need to correct it. It is probably one investigation which we should add to our list of investigating psoriasis patients. As an adjunct, yes. Monotherapy, I would say no. Anything else before we break? Yes, madam. Yeah. See, the thing is, tofacitinib is a very inexpensive and very strong immunomodulator. It's a strong immunosuppressive. Tofacitinib has a license for prescription only in psoriatic arthritis, not in psoriasis. We are talking about psoriatic arthritis because we want to reserve tofacitinib for really bad patients of psoriasis. We are not interested in giving tofacitinib for simple plaque psoriasis because we have other safer options available. That's the only thing. And one of the questions that actually came was, can you combine tofacitinib with other immunosuppressives? I have seen rheumatologists doing that. But I think we are walking a very dangerous line over there. We're walking on thin ice. Just yesterday, I saw a patient who was prescribed just 15 milligrams of tofacitinib per day and went into myelosuppression. So a little difficult to predict. Obese patients who have taking tofacitinib, psoriasis, comorbidities, most common one is obesity or weight gain. They're very prone for the DVT. I think that when we choose a drug, we should choose a drug with which can be maintained on a very long-term basis and with the least probability of developing a side effect. Therefore, I would stay away from tofacitinib, but in a case of psoriatic arthritis, which is life-altering, I don't mind giving tofacitinib. But even there, unlike what rheumatologists do, they give it along with methotrexate. I wouldn't advise combining with methotrexate. This is not a recognized combination. Topical tofacitinib, I don't think is going to work in a systemic problem like psoriasis.
Good afternoon, sir. So, what would be your treatment protocol for a patient planning for pregnancy with psoriasis or currently pregnant?
There are two parts of this question. Patient planning for pregnancy, I think we should be a little careful with any immunosuppressive drug. For each drug, there are washout periods that have been mentioned. If you are talking about methotrexate, we want 3 months away from methotrexate when the patient is planning conception. A drug like apremilast, we are talking about 1 month away. When a drug like a drug like acitretin, we are talking about 3 years. So we have to be a little careful about that. But when it comes to a biological, actually speaking, it doesn't seem to make a difference. We don't have hard evidence because all the trials for biologicals were done excluding pregnant patients. So the evidence is not there, but personally speaking, I'll tell you, I have used biologicals in patients both planning pregnancy and patients who became pregnant. It does not make a difference, but the best drug that has been tested is Semzia, that is certolizumab. That can be given in a patient who wants to become pregnant. We don't have the drug. In India, I think we should be a little careful. Cyclosporin is not as harmful as any of the other drugs given in pregnancy. After the first trimester, your latitude for giving drugs is much better. For example, azathioprine is something which nobody discusses, but azathioprine is a fairly useful drug. But we don't give the milder drugs like apremilast during pregnancy. We don't have enough evidence. After the second trimester is over, then it becomes a little more easier to give drugs. But even there, we would like to avoid methotrexate. The serious problem of IUGR is there. So there we would like to, I'm talking about third trimester. I'm addressing each trimester, right? So this is what I would say regarding pregnancy and those who are planning for pregnancy. I've given you the washout period, the drug you would choose, and what you would use in a crisis.
So do you reserve Apremilast for older children, sir, about 12 years, or do you also use them in younger age group?
See, honestly, I don't mind using it in younger age group, but I have not done it very often. Only very few patients I have used above the age of 6 years. And Apremilast I have used after the age of 12 because that is a recommended indication. My practice is very defensive, very, very defensive practice, but I have seen in a couple of patients, I have used Apremilast in alopecia areata in the age above 6. It does actually help. Nothing bad happens. I've been corrected by Dr. Dheeraj, thank you for that. The washout period for pregnancy in Apremilast is 2 days. I made a mistake there. Thank you.
Thank you, sir.
Anything else? Okay. So I think with that I will request Dr. Pallavi or Dr. Dheeraj to give the concluding remarks, and I'm very grateful that we have a good audience on Psoriasis Day, and we have had a good discussion. I enjoyed it. I hope all of you did too. Thank you so much, and we have many more programs coming up for World Psoriasis Day. We have also launched a book on psoriasis, India's first textbook on psoriasis, which will reach every one of you eventually. Thank you so much.
Thank you, Dr. Murli. It was a wonderful moderation. And I thank you to all the doctors who have participated and joined us today. Firstly, we apologize for the technical inconveniences happened, but the panel discussion went well. And a heartfelt thank you to all the distinguished international speaker, Dr. Jennifer Soung, and all the three moderators, Dr. Murlidhar, Dr. Paras Ramani, and Dr. Sanjeev Kandhari. We are truly grateful for your presence and contributions, and a warm thank you to all the live audiences. Your presence made this session more meaningful. Thank you. I'm inviting Dr. Murlidhar to come to the stage for felicitation.
Okay. So on behalf of Glenmark, I would like to thank each and everyone, for taking a precious time and having this live session, international live session under the moderatorship of Dr. Yes. So that was a very helpful session, and Dr. Murlidhar was really, your kind words, your wisdom was there that helped entire audience. Now from our side, officially we would like to close the meeting, and we have lunch waiting for us. I'll request all the audience, we have a backdrop along with the instant photography. So I will request each and everyone to please take your selfie or take your photograph with the backdrop, and if you can, put your status today in terms of World Psoriasis Day. So thank you all. Thanks from our side.